Okay, welcome to Musculoskeletal Pharmacology. We'll begin with our NSAID analgesic. So NSAID is non-steroidal anti-inflammatory drug. Part 2 will be the opioid analgesics. Part 3, migraine, arthritis, and osteoporosis. 4, muscle relaxation, and then 5 is for gout. So let's start with NSAIDs. So we'll start with cyclooxygenase inhibitors, and cyclooxygenase is an enzyme that converts arachidonic acid into prostaglandins, and there are two different forms. There's cyclooxygenase 1 and cyclooxygenase 2, which we refer to as COX-1 and COX-2. So as we're looking at the enzyme form, COX-1 is considered the good COX, and we'll see why in a second. It's located in all the tissues, and it has three primary functions. So it's going to protect the gastric mucosa, support renal function, promote platelet aggregation. But if you inhibit this, as some of the NSAIDs will, then you would get gastric erosion, ulceration, renal impairment, and bleeding tendencies. COX-2 is the bad COX, and it's the site of tissue injury, brain, kidneys, blood vessels, colon, and it mediates inflammation, mediates fever, and reduces perception of pain, promotes renal function, promotes vasodilation, but it also contributes to colon cancer. So if we inhibit this one, we're going to suppress inflammation, alleviate pain and fever, and protect against colon cancer. So you can see here the result of inhibition of gastric erosion and ulceration, renal impairment, bleeding tendencies, usually bad, versus suppressing inflammation, alleviating pain and fever, and protecting against colon cancer, which is good. So they're going to fall into two primary categories: those that block inflammation, the non-steroidal anti-inflammatory drugs like aspirin, and first-generation non-steroidals like ibuprofen and naproxen, meloxicam, and then there's the second generation NSAIDs like celecoxib, and we'll talk about those. On the other side, there are some drugs that don't block inflammation. This is acetaminophen, which you know better as Tylenol. So the big difference is one blocks inflammation and then the other side doesn't. So we'll start with the most common non-steroidal anti-inflammatory drug, or certainly the first, was aspirin. And the ASA stands for acetylsalicylic acid, and that's often an acronym that someone will use. So non-steroidal anti-inflammatory drugs, this is an irreversible, non-selective COX inhibitor, and therapeutically we can use it to suppress platelet aggregation, protects against myocardial infarction, heart attack, and stroke on the COX-1 side. And the guidelines for that have changed quite a bit recently because of the way that they've found that in certain patient populations, that daily aspirin is something that really the prescriber needs to manage. COX-2, we can get analgesia, which is pain relief, antipyretic, which is reducing fever, anti-inflammatory, reducing inflammation, helping with dysmenorrhea, so painful menstrual cycle, preventing cancer, and then Alzheimer's disease prevention as well. So plenty of things that aspirin can do, and we may be actually not using it enough, but there's certain ways that it's safe and it's not. So let's go into the adverse effects. So the GI adverse effects, we can have bleeding, renal impairment. Salicylism is where you can get tinnitus, which is ringing in the ears, sweating, headache, and dizziness. Reye's syndrome in children. So we don't want to give aspirin to children, and you'll see now that there's no children's aspirin. It's called low-dose aspirin. And we also want to be careful of other drugs like bismuth subsalicylate, which is Pepto-Bismol, that also has a salicylate component. It's a pink liquid, so you think, kids can take it, and that is not the case at all. In pregnancy, we can see anemia, postpartum hemorrhage. It may prolong labor, and then hypersensitivity reactions, as some people are very, very sensitive to aspirin. And most are seen from inhibiting or blocking these COX enzymes. So let's look at some drug interactions for aspirin. On the left-hand side, we have drug interactions: anticoagulants, warfarin and heparin, glucocorticoids, alcohol, ibuprofen, ACE inhibitors, and ARBs, so angiotensin-converting enzyme inhibitors and angiotensin II receptor blockers. Acute poisoning signs include respiratory depression, hyperthermia, dehydration, acidosis. These are serious and life-threatening. So notes, aspirin interacts with a lot of common things, so be sure to get an accurate medication history. And then treatment for poisoning requires hospitalization, but is generally supportive care. First generation non-aspirin. So aspirin-like drugs with fewer GI, renal, and hemorrhagic effects than aspirin. They inhibit COX-1 and COX-2. The inhibition is reversible, unlike with aspirin, and it's used for rheumatoid arthritis and osteoarthritis. So there are more than 20 non-aspirin NSAIDs available. Patients tend to do better on one drug than another for unknown reasons, despite them all being similar. And they do not protect against MI and stroke because they have little antiplatelet activity. So let's look at some specifics: ibuprofen, naproxen, meloxicam. So ibuprofen, which is brand Motrin, brand Advil, naproxen, brand Aleve, all of those are found over the counter. And then meloxicam, or brand Mobic, is a prescription. So the indications include analgesia, so pain, antipyretic, fever, anti-inflammatory, inflammation, and arthritis relief. On the adverse drug reaction side, they're generally well tolerated, but they can cause nausea, vomiting, bleeding. So all first-generation NSAIDs are associated with an increased risk of GI bleed that can lead to hospitalization or death, so you do want to be careful with these. The second generation selectively inhibits COX-2, and it's just as effective as traditional NSAIDs in suppressing inflammation and pain, but there's somewhat lower risk for GI effects. So it can impair renal function, cause hypertension and edema, increased risk for MI and stroke. So the example here is celecoxib, or Celebrex, and because of the cardiovascular risk, it's one of the last choice drugs for long-term management of pain. Indications include osteoarthritis, rheumatoid arthritis, acute pain, dysmenorrhea, familial adenomatous polyposis. And adverse drug reactions include dyspepsia, abdominal pain, renal impairment, sulfanilamide allergy, cardiovascular impact, stroke, MI, other serious events, and then its use in pregnancy. So we want to be careful with celecoxib. Acetaminophen, or APAP, which is N-acetylparaminophenol, it inhibits prostaglandin synthesis in the central nervous system. It doesn't have anti-inflammatory, anti-rheumatic properties, and we don't have to worry about Ray's syndrome. We can use it for analgesia, antipyretic, or fever, or arthritic pain without inflammation, but it doesn't help with inflammation. Adverse drug reactions are rare, but we can get Stevens-Johnson syndrome, acute generalized xanthine pustulosis, and toxic epidermal necrolysis. With acetaminophen, we worry about hepatotoxicity, hepatic necrosis, which can cause coma or death, so liver damage. So these can occur with those with liver damage or overdoses. So signs and symptoms in the early presentation would be nausea and vomiting, diarrhea, sweating, abdominal pain. Drug interactions include alcohol, warfarin, and vaccines. Notes, the maximum acetaminophen dose is 3 grams per day, or 3,000 milligrams per day. The alcoholic patient's maximum dose would be 2 grams per day. They have some kind of damaged liver. And overdose is treated with N-acetylcysteine, brand Mucomyst, immediately. We may have a combination drug. One good example is aspirin with acetaminophen and caffeine, or brand Excedrin. So caffeine causes cerebral vasoconstriction in the brain, hopefully to relieve the headaches. And persons under 18 shouldn't use because of the risk of Ray's syndrome and the acetylsalicylic acid, or the aspirin. But the idea is that we're giving an anti-inflammatory with aspirin, a drug that relieves pain with acetaminophen, and a drug that causes vasoconstriction with caffeine. Opioid analgesics, so these are the most potent analgesics we have. And there are 3 different classes of opioid receptor. There's the mu receptor, and when we activate this, it causes analgesia, respiratory depression, sedation, euphoria, physical dependence, decreased GI motility. For kappa, it's causing analgesia, sedation, decreased GI motility. And then delta, opioids don't really react with delta receptors. Let's talk about the DEA schedules. So all medications that work on opioid receptors are controlled substances. And to make clear, if we have a Schedule 1, there's supposed to be no medical use, and these are illegal. But you'll say, well, marijuana is legal in some states. Yeah, right now federal law still, it's illegal under federal law, but states have made it legal for either recreational or medical or both use. But let's look at Schedule 1. So some examples would be heroin, marijuana, and ecstasy. Schedule 2, fentanyl, oxycodone, Adderall, cocaine, hydrocodone. Schedule 3, acetaminophen with codeine, testosterone, anabolic steroids. Schedule 4, Tramadol, Xanax, Ativan, and Ambien. So some pain medications, benzodiazepines, sedative hypnotics. And then Schedule 5, Cherotocin, which is a cough medicine, Lomotil for diarrhea, Lyrica, which was a antiepileptic. So the abuse and dependence potential decreases as the schedule number increases. So something like morphine, it's strong agonist for the mu and the kappa receptors, and the opioid that all other opioids are measured against. So the indications are relieving pain without the other senses, sight, touch, smell, and hearing. There's no loss of consciousness. Adverse drug reactions include respiratory depression, constipation, urinary retention, orthostatic hypotension, emesis, meiosis, so those pinpoint pupils, cough suppression, biliary colic, intolerance, and physical dependence. Some of the adverse drug reactions that we have to worry about especially are respiratory depression. So the infants and the elderly especially sensitive. And the onset with intravenous is 7 minutes, intramuscular 30, subcutaneous up to 90 minutes. And it can persist up to 4 or 5 hours. Spinal injection, the response may be delayed by hours. Tolerance to respiratory depression can develop, and then increased depression with concurrent use of other drugs that have CNS depressant actions. And it can certainly compromise a patient with impaired pulmonary function, and this makes sense. We're depressing the respiration. Constipation, the cause, well, we've got suppressed propulsive intestinal contractions. It's intensified non-propulsive contractions, increased tone of the anal sphincter, and then inhibition secretion of the fluids in the intestinal lumen. The complications include fecal impaction, bowel perforation, rectal tearing, and hemorrhoids. And treatment includes physical activity, including intake of fibrin fluids, stimulant laxatives, stool softeners, and polyethylene glycol. Adverse drug reactions, so we worry about euphoria and dysphoria. So an exaggerated sense of well-being caused by the activation of mu receptors is euphoria. Dysphoria is a sense of anxiety and unease. And then dysphoria is uncommon among patients in pain, but it can occur with morphine in the absence of pain. Also, we'll see sedation, drowsiness, some mental clouding, potential coma. Avoid hazardous activities like driving. Sedation can be minimized by taking smaller doses more often, using opioids with shorter half-lives, giving small doses of CNS stimulant, for example, methylphenidate or dextroamphetamine, and then non-amphetamine stimulants like modafinil, which is Provigil or Alertec, or armodafinil, which is Nuvigil. They can also be tried. So meiosis, this is pupillary constriction, so toxic doses may constrict a pinpoint size, and it's similar to pupils in bright lights. It's caused by morphine and other opioids. The pharmacokinetics, so the kinetics are what the body does to the drug. So it's administered by several routes. You've got oral, intramuscular, intravenous, subcutaneous, epidural, intrathecal. It's not very lipid soluble, and it doesn't cross the blood-brain barrier easily, and only a small fraction reaches the site of analgesic action. But the issue we have is morphine tolerance. So increased doses need to obtain the same response. It develops with analgesia, euphoria, sedation, respiratory depression. There's a cross-tolerance to other opioid agonists, and there's no tolerance to meiosis or constipation develops. Physical dependence, so you've got abstinence syndrome with abrupt discontinuation. So about 10 hours after the last dose, the initial reaction occurs, includes yawning, rhinorrhea, and sweating. Progresses to violent sneezing, weakness, nausea, vomiting, diarrhea, abdominal cramps, bone and muscle pain, muscle spasms, and kicking movements, and lasts 7 to 10 days if untreated. Withdrawal is unpleasant, but not lethal as it may be with the CNS depressants. So fentanyl is one of the most potent. It's given via 3 routes: parenteral for surgical anesthesia, transdermally is Duragesic, and the patch has a heat acceleration. Transmucosal, so launched on a stick like Actique. Buccal film, Onsilis. Buccal tablets, Ventura. Sublingual tablets, Abstral. And sublingual spray, which is Subsys. So it's 100 times more potent than morphine. So you can see here next to a penny just how little medication it takes. Should be reserved for cancer patients, end-of-life care, and patients who have used opioids first and are tolerant. Never give an opioid-naive patient fentanyl. So other agonists: codeine, fentanyl, oxymorphone, methadone, hydromorphone, oxycodone, meperidine, hydrocodone, levorphanol, remifentanil, tapentadol, and alfentanil. So let's look at Tramadol, which is Ultram. It has weak mu receptor activity. Most of the analgesia comes from norepinephrine and serotonin blockage. The indications include moderate to severe pain. And then adverse drug reactions include sedation, dizziness, dry mouth, and constipation. The nursing considerations would be lowering the seizure threshold and making them more likely, and then increases CNS depression when combined with opioids and benzos. We look at the opioid toxicity, and we're looking for this triad, which is respiratory depression, severe sedation or coma, and meiosis. The treatment would be an opioid antagonist, which is naloxone or brand Narcan. We want to monitor the vitals before using, and we are looking for a respiration less than 12 per minute. We give on a fixed schedule with ventilation support. Opioids antagonist, so it has a higher affinity to the receptor than opioid medications. It'll force opioids off receptor, and the receptor will no longer be active and cause effects. So there's only one available. It's naloxone, brand Narcan. And it should be used in the event of overdose to reverse the effects. So it's available as an intranasal spray, intramuscular injection, oral tablet. But don't use it for overdose. It just works too slow. So now that we've gone over the opioids, let's go on migraine, arthritis, and osteoporosis medications. A migraine is a neurovascular disorder that involves dilation and inflammation of the intracranial blood vessels. So we've got this neural trigger, vasodilation and inflammation, and then that goes to neural activation and signal amplification. So the trigger turns on the radio, causing vasodilation and inflammation. The radio activates the speakers, further activating the brain, and the radio waves carry the signal even further, and it's amplified and pain increases. There are two compounds that we think are at play. Calcitonin gene-related peptide, CGRP. It promotes migraines, elevated during migraines. And 5-hydroxytryptophan, which is 5-HT or serotonin, which suppresses migraines. But the plasma levels drop during the migraines, so giving more 5-HT during the migraine can abort it. So we've got two options. We can either abort the ongoing attack and stop it with aspirin-like drugs or migraine-specific drugs, serotonin 1B, 1D receptor agonists, or we can prevent them from occurring. And we use anti-epileptic drugs like Davoproix, which is Depakote-ER, or gabapentin, which is Neurontin, tricyclic antidepressants like amitriptyline, brand Elavil, and beta blockers like propranolol. Now you say, how did they figure out that these work for migraines? Well, Davoproix and gabapentin are both seizure drugs, and if a patient was having seizures and they were treated in this way and they also had migraines, they may have reported that, hey, my headaches and migraines have gone away since I've been on this medicine. And so the researchers investigate. Same thing, someone was depressed, but they got amitriptyline and they had migraines and it went away. And finally, beta blockers or propranolol, same thing, where they had high blood pressure, maybe they got propranolol as a medication, and the migraine went away. So our staple for use is the triptan, the serotonin 1B, 1D receptor agonist. It aborts an ongoing migraine attack to relieve headache and associated symptoms. You've got oral intranasal forms, and these are analogs of serotonin. So they bind to serotonin receptors in blood vessels, they cause vasoconstriction, and they suppress CGRT, reducing inflammation. So it basically turns off the radio. There are many drug reactions that come along with this. So you can have chest symptoms, very heavy arms or a chest pressor, coronary vasospasm, which is a rare angina as a result of vasospasm, teratogenesis towards the fetus, and then some others like vertigo, malaise, fatigue, tingling sensations, and a very bad taste when taken in intranasal form. So when we look at them, we see that there are many that we use, but sumatriptan and elatriptan are the most common. But sumatriptan, naratriptan, rizatriptan, zolmitriptan, almotriptan, frovatriptan, elatriptan, these are all common ones. Rheumatoid arthritis, an overview. So the autoimmune disorder that causes joint inflammation, damage, and pain. Our treatment goals are to relieve symptoms, maintain joint function, minimize systemic involvement, and delay progression of the disease. The drugs we use to treat are NSAIDs, DMARDs, and glucocorticoids. So let's start with the treatment. Start with a DMARD early. NSAIDs are given until the DMARD is effective, and then add other agents as necessary. So non-steroidal anti-inflammatory drugs, we've got the first generation NSAIDs, which inhibit COX-1 and COX-2. And we've got the second generation NSAIDs, the COXIBs, which selectively inhibit COX-2, like celecoxib. NSAIDs only help with symptom control. They don't prevent disease progression. So nursing considerations that all prescription NSAIDs carry a box warning about the risk of thrombotic events and GI ulceration and bleeding. So let's look at the help with the symptoms and slow disease progression. So we can have generalized symptoms, which are all over the body, the oral glucocorticoids, and we can have local symptoms, 1 to 2 joints, where we can have an intra-articular injection. Long-term use should be avoided due to toxicity, osteoporosis, gastric ulceration, adrenal suppression. There are many disease-modifying anti-rheumatic drugs, and they help with symptom control and slow progression. They're potentially more harmful than NSAIDs and require monitoring. But methotrexate, sulfasalazine, leflunomide, hydroxychloroquine, minocycline, penicillamine, azathioprine, cyclosporin, all of these can be used. Methotrexate is the fastest working DMARD. It improves within 3 to 6 weeks for patients, and at least 80% see improvement. But monitoring is required. Adverse drug reactions include hepatic fibrosis, bone marrow suppression, GI ulceration, and pneumonitis. Tumor necrosis factor inhibitors help with symptom control and slow progression. We work by suppressing the immune system and putting the patient at risk of serious infections, unfortunately. But etanercept, adalimumab, certolizumab, golimumab, and infliximab are options. Another biologic is etanercept, or Enbrel, which is a tumor necrosis factor inhibitor. It helps with symptom control and slow progression, and it's for use with moderate to severe rheumatoid arthritis. So we can have serious infections, allergic reactions, heart failure, hematologic disorders, liver injury, and CNS demyelinating disorders. T-cell activation inhibitor, so we help with symptom control and slow progression. That's for use with moderate to severe RA, and we have adverse drug reactions like headache, upper respiratory infection, nasopharyngitis, nausea, serious infections. And that's abatacept aurencia. Osteoporosis is the next thing we'll tackle. The pathology is that we have a low bone mass and bone fragility. Bone is the largest source of calcium in the body. When the body is low on calcium, osteoclasts will break down the bone and structure to free calcium. And then osteoblasts, which is the crane, will build the bone structure back up using calcium in the circulation. Osteoporosis bisphosphonates, analogs of pyrophosphate incorporating into the bone, prevent osteoclasts from breaking down and releasing calcium. The indications include postmenopausal osteoporosis, osteoporosis in men, Paget's disease, glucocorticoid-induced osteoporosis, hypercalcemia of malignancy. And some drugs that we can use are alendronate, brand Fosamax, ibandronate, brand Beniva, and then tilidronate, brand Skilid. So let's look at alendronate first. It's the most common bisphosphonate used. It's dosed once weekly. It's very poorly absorbed, less than 1%. So we want to take steps to maximize effectiveness. We've got to take it on an empty stomach with a large glass of water. Even coffee and juice can prevent absorption, so we'll avoid that. So watch for esophageal inflammation and ulceration or esophagitis, and the patient must be sitting, standing for at least 30 minutes after taking with a large glass of water. Ibandronate or Beniva, it's dosed once weekly or once monthly. It's very poorly absorbed orally, less than 1%. And steps have to be taken to maximize effectiveness. So it must be taken on an empty stomach, large glass of water, and then same thing, esophageal inflammation, ulceration. Patient must be sitting, standing for at least 30 minutes. OTC supplements include primary prevention for the development of osteoporosis, so calcium, citrate, and carbonate, both appropriate, absorbed best in an acidic environment. Vitamin D is cholecalciferol, ergocalciferol, fat-soluble. Toxicity is a big concern. Vitamin D toxicity is rare and involves large amounts to be taken. Regular weight-bearing exercise can be greatly beneficial as well. Muscle relaxers like cyclobenzaprine, so we have involuntary contraction of muscle or a group of muscles. This is cyclobenzaprine, which is Flexeril. Works at the brainstem to reduce tonic or muscle tone activity, and we want to watch out for drowsiness, no driving, and then don't take an SSRI or SNRI because of a risk of serotonin syndrome. Diazepam is an we worry about the same things with that we have with cyclobenzaprine, but this is a benzodiazepine, and we're worried about drowsiness again. Don't mix with alcohol with the risk of CNS depression. The final group of the gout medications, so it's the disease of kings, likely because the kings feasted on beer and meats and all those things, and it would cause uric acid to build up, usually in the big toe. So uric acid crystallizes, you get sharp, severe joint pain, and the chronic treatment involves decreasing uric acid levels. So NSAIDs are used as first line in acute flare-up treatment. Last one are the xanthine oxidase inhibitors, so they prevent uric acid from being produced. They also break down any uric acid deposits or crystals that have been made. So allopurinol or Xyloprim, this is a cheap generic that can cause fatal hypersensitivity syndrome. And then robuxostat, should be febuxostat, which is Uloric, expensive brand only, and increased cardiovascular risk at higher doses.